Please note that this meeting is being recorded. If you do not consent to being recorded, you are asked to drop off the meeting at this time. Thank you so much for your understanding and cooperation. You're also welcome to change your name or turn your video off. And I'll pass off to Alicia.
Yes, so thank you everyone for being here. My name is Alicia Sneddy. I'm one of our public health project coordinators here at the National Indian Health Board, working on a maternal child health team. And if you're new here, I just wanted to share some light on our wonderful team. We have Dr. Jill Jim, Renee Boyner, and Liv Hoynes. And I also like to add that our team is currently hiring, so we invite you to apply or share with your networks, and always feel free to reach out to myself or anyone on our team if you have any questions about that. We'll go on to the next slide. And so if you haven't heard about the National Indian Health Board, we wanted to share more about our mission and vision, and that the National Indian Health Board was founded by the tribes to advocate as a united voice of federally recognized American Indian and Alaska Native tribes. And within NIHB, a public health team works to empower sovereign tribal nations to improve equity, policy, and public health systems that help build thriving Native communities now and for the next 7 generations. And with the purpose of our Tribal Learning Community Series is really to create a space and to connect with one another, as we're coming from different parts of Indian country and coming from different backgrounds, experiences, and working across different and awesome organizations and communities. So a maternal child health team works with the CDC to help implement the Hear Her campaign, which I'll be sharing more information here soon. And the Hear Her campaign is for American Indian, Alaska Native communities, and to explore, and our project with the Hear Her campaign is to explore the feasibility and implementation of, sorry, I'm sharing wrong information. So we have the Hear Her campaign, and for our Maternal Mortality Review Committee project, our goal is to explore the feasibility and implementation of tribally led MMRCs, which is Maternal Mortality Review Committees. And so we're excited to share newly released Hear Her materials and opportunities of how everyone here can share the campaign in their tribal communities or organizations. And I'll pass it back to Liv to share some ground rules and reminders and going over today's agenda.
Thanks, Lisa. Since we will be connecting with each other in the chat and in breakout rooms, we wanted to share a few ground rules to remain curious, to pause and listen first, to know that we expect effort but not perfection, and that this is a space that's also meant to build community and connect with one another. As you feel comfortable, we hope that you will exchange ideas, emails, or opportunities together. Importantly, we know that this is a heavy and personal topic to many of us. We invite you to step away if needed. We invite you to take time to care for yourself and to access your support systems. Another couple of reminders: everyone will have access to today's recording and presentation slides within 1 week post-event over email. If you have any questions accessing that, please feel free to reach out to myself or Alicia. And so for today's agenda, we'll start by highlighting some critical resources through the Hear Her campaign, followed by our wonderful presenter, Dr. Janelle Palacios. We will then have time for a question-answer session, and if time allows, we plan to go into breakout rooms to have some small group discussions and uplift your ideas and experiences. The evaluation for today's session can be found in the chat, and we will share this a few times throughout the session. Please take a moment to complete this. We really value and we really do use your feedback.
Awesome. Thank you, Liv. So I wanted to take a moment to share our, but in partnership with the CDC in sharing the Hear Her campaign for American Indian, Alaska Native communities. The Learning Community Series is grounded in the power of storytelling and centering lived experiences. And the CDC's Hear Her campaign for AIAN people is a wonderful resource for our American Indian Alaska Native people who are pregnant or postpartum, their support networks and healthcare professionals who serve them. And the campaign centers and uplifts the stories of 5 American Indian women who tell their stories on video. And we'll share a link here where if you haven't came across the resources, we would love to share that with you all today. And Liv will be sharing a 30-second PSA video, and it's a brief video introduction to the Hear Her campaign. And there are shareable graphics, posters, palm cards, and more, which are all available for free, and we'll share some more information about that. I don't hear the audio, right, Liv? Is that just me?
No, I think let me try again. Sorry about that. Can you hear now?
Yeah, it should be on your top on your tools when you're viewing or sharing your screen, I believe.
If I can't do this, then I'll put the link in the chat so everyone can.
Yeah, that's just 30 seconds, people. Can you guys have time to review a few later today? That works. Thanks, Liv. Well, perfect.
The circle of life begins with the birth of a child, and that journey begins with pregnancy. People who are pregnant or who have had a baby know their bodies and know when something does not feel right. When they speak, we must listen. Hear her. Learn more at cdc.gov/hearher/.
Thank you for bearing with me through that.
No, thank you, Liv, for sharing. Perfect. Okay. So, and these are just some of the different ways that organizations, communities can work to implement the Hear Her campaign. As we mentioned, there's different posters, handouts, social media posts, and amplifying the Hear Her stories, which we just watched a short PSA video on, and the possibility or opportunity to order posters and palm cards in print at no cost, and sharing also the opportunity to syndicate the Hear Her webpage to your own website, so others who are seeking maternal health resources can be linked directly to the CDC Hear Her campaign resources. And also want to shed some light of the opportunity that communities and tribal nations can co-brand Hear Her resources with your own tribal sale. And we'll share the contact information to Sarah Kerrigan, who's our health communication specialist, and I can work with communities on that, or us too. So feel free to reach out to myself or Liv. And lastly, before I turn it over to Dr. Janelle Palacios, we have an upcoming Maternal Health Promotion Institute. So it'll be our 2nd annual gathering on a virtual base on August 8th and 9th, and we'll share the registration link here soon. So, and it's free and it's for anyone. Just looking at where the Promotion Institute will be sharing culturally centered practices, strength-based approaches, and equitable solutions that are making a positive impact on the health and well-being on Native families, children, and communities. And we hope to see everyone there. So thank you. And now I pass it on to Dr. Janelle Palacios, and we'll stop sharing our screen now. Thank you so much, everyone. And thank you, Janelle.
My pleasure. Thank you for having me. I am just getting the slides ready to go. Okay, everyone can see it. Thumbs up. Okay, perfect. Hesquex, good morning, good afternoon. I'm Janelle Palacios. I'm Salish and Kootenai, born and raised on the Flathead Indian Reservation in northwestern Montana, the pretty side. And I'm just so happy to be here. I'm a nurse midwife but I'm also a researcher, a consultant, and now a businesswoman. Can you believe it? Entrepreneur natives, get out there. And I am here today to share with you my expertise and insight on perinatal mental health concerns. So I just would like to first open up with everyone and share that I'm not going deep into issues that might be triggering. So normally a lot of my presentations can be triggering on the triggering side, because I talk a lot about historical trauma and context. And I'm not going to be doing a lot of that today. We're going to focus on more of the here and now, but some of what we may talk about may jog your memory of current clients or community members or family members or yourself, and it can be triggering in that way. So I just want to warn you all about that, all right? Beautiful flathead, yes. I took a quick peek to see who was present and who raised their hand, so to speak, and said, hey, I'm here. And I see a lot of nurses. I see a good amount of public health people from a lot of Native programs and some state agencies. So I'm really happy to see that. So I will share with you that as we get into this presentation, I'm going to do a brief recap of the prior two presentations just to kind of situate us, because I think it's really important to look at those two prior presentations to understand how women and birthing people can come to this place of mental health issues during their pregnancy and after and postpartum time. I myself am a mother of 3 children. Everyone believes their own children is more beautiful than others. So I would say I have 3 beautiful, beautiful children. And I would say that I was scared to death becoming a parent. I wanted to be a parent, but I was really scared because I myself remembered my own mother's parenting, and I was raised by a single mother, and I did not want to be like her. In that now I recognize as a nurse midwife, someone who's done a lot of work with pregnancy and postpartum families, that what I experienced as a child with my own mother was that she was severely depressed and had perinatal mental health, anxiety and depression. And as a child, I could see that that was a way I didn't want to be. And so I was afraid to become a parent. And when I actually became a parent, although I was really nervous, I found that one of the biggest reoccurring symptoms I had, and I disclose my symptoms with every family that I meet when I speak to them postpartum. I share with them, I disclose that I myself experienced postpartum depression, and that my main symptom was that I was super forgetful for like 6 years straight. I have a friend, a very dear friend, and only dear friends can say this to you, but she said to me that she believes my IQ dropped quite a bit with every child I had, because that's how spacey my mind was, right? So it is a very real issue and it affects people's lives. So as we go on, I will share. Here's the brief recap of Dr. Brian, I am sorry, I wrote Biren, but it's Brian Thompson's presentation. He gave a wonderful presentation on maternal mortality review and morbidity concerns. And basically, our nation, even though it's developed, we have increasing rates of maternal death and infant death for that matter. So even though we are a developed country, we're wealthy, we have the worst outcomes among our pregnant and postpartum families. When we look at Native people in this mortality and morbidity issue, we are not keeping great data. So we don't really know the breadth of the severity of mortality and morbidity among our Native women and families and birthing people. We just don't know. Thank goodness Arizona did a really great brief from 2016 to 2018. I read it. I met one of the statisticians that participated in that study, that brief report. And it's really great that we have that, but we don't have that for every state, and we don't have that really for a nation. And as you might recall, as people are understanding how Native American people are categorized on, certain national vital statistics, that we've come to understand that oftentimes Native people are only categorized if they only account for one race, one ethnicity. So all of us who are mixed Native people, our data is not always captured in state or national data. So it's not giving a great representation of our data. And then in addition, we don't know what's going on with Indian Health Service. They have the numbers, they have data, but they have not published this data. So we don't know what's going on within Indian Health Service as a federal entity or within regional areas. But we do know that we need data and that there are some statewide and local reports out there that indicate that our Native women and birthing people are not faring well. So living on reservations with or without prenatal care doesn't matter. You still have high morbidity rate. And this was seen in Arizona. So remember, Dr. Brian Thompson talked about like 300, that about 3% of Native women, so 3 out of 100 women will have a severe morbid event during the hospital stay or around the peripartum time, and compared to about 1 white woman. So that's pretty significant. And we only know that because Arizona did that study. They looked at the data. So 31% of Native maternal deaths are related to mental health, and most of these maternal deaths have been shown to be preventable. So there's a lot to do. So we're in a severe mental health provider shortage, as well as people who live in rural areas are especially impacted by this shortage because we have maternity care deserts. We actually, the March of Dimes released the report a few years ago where we see providers, the very few obstetrical providers out in rural areas are actually leaving because they don't have the resources, and it's really difficult to keep provider specialists in rural areas. And that means the burden of travel is placed on women and families. We also know equity is needed. So if, for example, Dr. Brian Thompson talked about the scale of how the federal government pays expenditures per person in different health plans. So Medicare is wealthy-ish. It has about maybe $15,000 spent per person, and Medicaid is about $8,000 spent per person, whereas Indian Health Service has a paltry like $4,000, a little over $4,000. So there's severe funding shortage and chronic underfunding of Indian Health Service. Dr. Thompson also talked about how we're stronger together than apart. So think of that arrow bundle, especially on the dollar bill sign. Another idea is think about having to break a whole 2 packages of spaghetti sticks in half. Like, it's really hard to break a whole bunch of spaghetti sticks, right? So the more that we are able to cohesively work together, the more difficult it is to kind of have these maternal outcomes, these worse maternal outcomes, if the system around us is caring for all of us equally, equitably. So the burden of the outcomes is, Dr. Brian Thompson was trying to help people understand that we shouldn't place the burden of hemorrhage or hypertension or mental health on the birthing person or a woman's shoulder. It's a systemic issue that we need to address. So that was Dr. Brian Thompson's presentation. And then just a brief recap of the Alaska Native Birth Workers presentation. So remember, they shared that, data has shown that a constant companion, like a doula, care improves maternal and infant outcomes, especially during labor and delivery. The Alaska Native Birth Workers supports Native birthing families. They do this in a number of ways. They have virtual drop-in circles where they share traditional arts, traditional knowledge. They also have in-person traditional arts and crafts. And but it's all around the sharing of traditional cultural knowledge and practices to build a sense of cohesion and belonging amongst people and community members and to connect them. And what do people do when they get together? They chat. There's a time during this where interventions can be done, whether it's education or just having people kind of debrief and kind of chat about what's going on in their lives. And that can be therapeutic in itself. So the Alaska Native Birth Workers community, they collaborate with partners and they're trying to really address systemic change, especially within Alaska. They acknowledge that colonialism continues to impact health and well-being of their population. And they talked about how birth was colonized, how midwives were taken out of their place. And in the lower 48, Native midwives were actually barred, they were banned from practicing in their communities, or when they were put on reservations, And it was historically, it was the War Department, like physicians that came in and attended to people at some point as Native birth workers were pushed out, and it was made illegal and banned. So they shared how that in Alaska, not only has the midwifery changed from a cultural practice and knowledge source to one that has become heavily medicalized. And that's done across the nation with the changing of medicine and how medicine views health. Health is, the body typically is viewed as an illness, that there's only illness, and midwives tend to have a more holistic view of the person. So this whole transition from what normal looks like, or what the holistic view of the person, has changed and has infiltrated how people actually practice. Midwives can practice, especially in a hospital setting where it's very medicalized. They talked about how a number of Alaska Native women are actually evacuated. They're evacuated from their village and brought into Anchorage, right, into a larger city. And then they have to kind of wait days, weeks, and sometimes months when they are away from their family in order to give birth, especially if they have a complicated perinatal profile. So let's say someone who has hypertension on their way to preeclampsia, but they're also preterm, like at 32 weeks or 29 weeks. Those people are going to be kept in a hospital probably until they deliver. So that's months, weeks, days. And that's them being away from their family and functioning as a part of their family. So we have to think about how healing is not just for the self, which is what a lot of the Western dominant view of medicine is. It's healing of the self. And now the Western culture is trying to catch up to what a lot of Indigenous people understand in the worldview, is that healing comes from self, but also the wholeness with community, wholeness with family, and wholeness with land and ancestors. And that is what the Alaska Native birth workers with Abra shared with us. They talked about sovereignty from first breath, reclaiming power, which is so important because it's not only reclaiming traditional practices like midwives or doulas or birth workers being present and with women or with birthing people. It's also about reclaiming their own power when they're in the clinic getting care, when they're in the hospital room getting care. How many of you can think to your own birthing experience, or if you were in attendance with a family member, a loved one, or even if you were just in a hospital, how many of you truly felt that the person who was being serviced had agency, had the ability to ask questions and challenge the plan that the medical team decided what was best? How many of you can honestly say that shared decision-making was actually a part of it, where risks, alternatives, and benefits were shared? So like not just the positive things that could happen from this intervention, but also the negative things that could happen from this intervention. And what happens if we don't do anything, right? So how many of you can honestly go back and think about the shared decision-making from your own experience or with a family member's experience and feel that it was truly performed? I see a hand raised. Does someone have a question?
I was agreeing with both of your questions because I've personally had the experience where I can say I've had 2 successful births where I was listened to because I chose to give birth at home through a birth center in New Mexico called Breath of My Heart Birthplace. And I was thankful enough to also have my mother deliver my children. She's the first licensed Indigenous midwife in New Mexico, and she got to deliver my kids at my grandparents' house. And thankfully, there was no conflict because she's my mom, and obviously mother-daughter relationships, we'd probably have a little bit of friction, but it was a really wholesome experience.
Mhm. Thank you for sharing that. And congratulations on your mother being the first Indigenous midwife in New Mexico. That's amazing. And that's not like a small feat. Like that's a large feat to have undertaken. You're right. So the other issue is just having options, right? The ability, it is such a luxury actually in this country to have options of where you choose, where you want to have care provided, whether that's in home, at a birth center, with a midwife or with a physician, with a family physician or with an obstetrician or with a physician's assistant. Like there is a plethora of different ways that care can be handled, but it is a luxury in order to have that. And not everyone has that. Very few have that luxury. And that comes down to resources. I would just also like to say that that reclaiming the traditional practices, it's not just on the individual, but it is a community. And that's what a lot of the Alaska Native, American Indian, Indigenous birth workers are trying to do. They're trying to create networks and relationships with one another across our nation and across the sea to other Indigenous communities, but to have a place where we're not crazy because we understand the world in a different view, in a very Indigenous, holistic view of the world, where it's not just the individual's choices that matter, but the circumstances around them and the support they have, and how to bring that into these spaces to make it a pleasurable experience. Because the goal is not just to have a live mother, a live birthing person, and a live baby. That's not the goal. That's the bottom of the bar. Like that is the goal should be to have great experiences throughout this process and great outcomes, not just being alive. So what is the role of mental health during the perinatal period? You know, I will just say it is mainly in the past, I would say 5 to 8 years that we've really given a lot of attention on perinatal mental health. And before this, we really just looked at postpartum depression. And we only looked at maybe the first 2 years of, if you were lucky, the first 2 years postpartum after having a baby. We really looked at just like crying every day or every other day or a few times a week or a few times a month. We looked at symptoms such as like being angered or frustrated, having a short fuse. Maybe sometimes people talked about forgetfulness, although that was not necessarily heavily recognized. Permutation of having postpartum depression, and sometimes anxiety was included, but not always. Anxiety is relatively new into this area for providers understanding. I think on the research spectrum that was noted to be a little bit earlier, but anxiety was not really, is just now coming into this picture as part of the mental health issue and part of the perinatal mental health spectrum. So what is postpartum depression and what is postpartum anxiety? So we now understand that postpartum depression is really affecting after the first 2 weeks postpartum, because we give medicine gives a little bit of grace to those first 2 weeks postpartum, where people's hormones are changing drastically following the birth of an infant. And so someone can be laughing 1 minute and crying the next. And this can happen within hours after birth, minutes sometimes. Like it is a very impressive change. And oftentimes in our society, women are very stoic about their presentation of this, of being able to cry, even in a hospital setting following a delivery. So that postpartum depression is typically the 2 weeks after the birth to 2 years postpartum. And these are changes that affect her mental well-being, affect her ability to engage in the world, engage with her family, with her infant, and to bond with her infant, but also her overall physiological mental health as well. So we're looking at postpartum depression a little bit longer, for about 2 years. The anxiety portion as I mentioned, is more relatively understood to have come on the scene, where we now recognize it's a part of the mental health during the perinatal period. And it's part of the spectrum of the depression and anxiety, because people can still be depressed but have this anxious undertone to it. And their depression can come out more as anxiety and vice versa. So the anxiety would be a hypervigilance, where there's this concern that something bad might happen to the person themselves or to their baby or to both of them. It is this anxiety about making sure that the baby's alive and breathing. And that's just not rarely done. I mean, it's something that's on the person's mind. It's a fixation on something going wrong, right? So just to share with you, this is I have a cutout from the Perinatal Institute, and it talks about perinatal mood and anxiety disorder. So this is just a little snippet of what some of these symptoms might look like. It might be depression, and depression can be, again, quick to have a short fuse or be angered or frustrated. It can be crying every day or a few times a week or a few times a month. It can be being super forgetful. Like I mentioned, I was super, super forgetful in my own postpartum depression experience. It can also be then anxiety, this overwhelming feeling that something bad is going to happen, that something might not happen. Under that depression also might be symptoms like not being able to sleep. So even though the baby is taken care of, the family is taken care of, and mom has time, protected time to rest, that person cannot shut their mind off. Their mind continues to talk to them and they can't get any rest. Aside from depression and anxiety, there can be this panic disorder where people have panic attacks. Their heart races, they feel short of breath, they feel like something bad is going to happen and they don't know what's going on. It's a very scary feeling. Some of this anxiety also comes out as obsessive compulsive disorder. And these are the people that are obsessively thinking that something bad is going to happen. You know, they might not even want to get in a car because they're worried about the odds of someone like crashing into them or them getting into a car accident. Or this is them locking the door a few times to make sure that the house is safe, or making sure that the baby is alive and breathing. Postpartum PTSD, we don't really talk about this very much, but birth trauma is something that is now more and more recognized as a phenomenon. So postpartum PTSD, whether it's from the experience of the actual birth, but we also have to remember that women and birthing people come into this space, they come into pregnancy having lived their life. And sometimes that life is having already experienced different forms of trauma, and in particular, sexual trauma. And that is something that I try to help the residents that I teach as a nurse midwife in the San Francisco Bay Area. I try to help people understand that the way that we engage with people is very, very important, and that we can sometimes inadvertently recreate or trigger trauma that people have experienced in their past when they come to us in labor or when they come to us through their delivery. So it's really important that we talk about postpartum PTSD or birth trauma as well. Bipolar disorders are a part of this. It's increasingly being understood that in the context of bipolar disorder, that this is a possible coping mechanism of the brain's way of survival, having experienced traumas earlier in their life. And it may manifest as a bipolar disorder. So if you see someone who has a history of bipolar disorder, really think about what may have happened earlier in their life, because the brain is so good at trying to compensate, it can create different methods of handling that trauma, whether it's dissociating, whether it is trying to only live in mania, having fun, good experiences, or whether it's this place of like severe depression. So it's really important that we think about bipolar disorders as a part of what's happened in that person's life earlier. And then postpartum psychosis. So people who have a history, who have any kind of history of depression, anxiety, panic attacks, a previous birth trauma, or if they're bipolar or they have a mood disorder, or I think another term is like adjustment disorder, like maladjustment disorder. These are like people who are difficult, that these are actually red flags that they are already primed for when they go into labor and delivery and have a birth, that, or they're pregnant, so pregnant or postpartum, that they're already at an elevated risk of having postpartum psychosis. And this is when the birthing person or the mom is so worried about her life or her infant's life or her family's life that they actually think about killing themselves or killing their family members in order to protect them from some other event that could happen. So this is the postpartum psychosis of harming self or harming others. And again, postpartum psychosis is actually an effect when people have already been primed, having experienced depression, anxiety, a history of bipolar disorder, maladjustment disorder, postpartum depression, or other birth trauma. What are the symptoms? I briefly went into some of these symptoms, right? So some of these symptoms of postpartum depression, anxiety would be this guilt that you're not a good mom, like you're the worst mom in the world, or you're feeling shame, or you feel helpless. Remember, I talked about disturbance of sleep. Like these people have protected time to sleep and they try to sleep and they can't turn off their mind. And sometimes it comes into their appetite where they just can't eat. Again, crying or sadness, worrying about things, having racing thoughts, not being able to focus, feeling anger, rage, irritability, scary, having intrusive thoughts. It also manifests as lack of interest in the baby, having a difficult ability to bond with the baby, just not being able to have eye contact with the baby, not wanting to snuggle or be close with the baby, letting other people do it, wanting other people to do it, right? Loss of interest or joy, pleasures of things. And we talked about the thoughts of harming yourself or your baby, that postpartum psychosis that can happen. The physical symptoms of some of the depression that can happen are like dizziness, hot flashes, shortness of breath, sometimes nausea. So it's a constellation of things of the mental health issues that can affect the physical well-being and manifest physically, as I shared. So amongst these symptoms, the big issue to take home here is just try to think of how many times you yourself have experienced this, whether you were pregnant postpartum or you've seen it in another friend or a family member, but it's very, very common. I would go on to say that almost everyone who goes through pregnancy and childbirth is going to experience at least one of these symptoms in their postpartum or perinatal time. It's just a matter of when we find it, when we screen for it. And just to share with you, it is considered a win that a pregnant or postpartum person is screened at least once during this perinatal time for postpartum depression or perinatal depression or anxiety. And that is the low bar. Okay, we should not be saying that we are winning when we only screen one time during her perinatal course for depression or anxiety. It should be ongoing. And I would advocate at every single point of contact, every time someone comes into clinic, every time someone is seen postpartum, that they should be screened. And even when the baby comes in for a baby well checkup, that the mother is screened or the birthing person is screened at that time as well. Just to share with you, 1 out of 5 pregnant or postpartum birthing people are diagnosed with mood or anxiety disorder during the perinatal period. Remember, during their pregnancy or postpartum period. And this is, again, just when we catch it. So if we were screening more frequently, I wonder if this number would go up, and I suspect it would. 1 out of 8 birthing people report symptoms of depression after giving birth. And BIPOC, Black, Indigenous, people of color women are experiencing higher rates of postpartum depression than white women, about 3 times the rate, depending on which data set you're looking at. And among Native women, There are regional differences, but about 14 to 30% of native birthing people have higher prevalence of postpartum depression than the US national average of 11%. And again, I would say this is probably an undercount and an underscreening. So what are some risk factors? So these are the general risk factors that would contribute to someone's predisposition of having a postpartum depression or anxiety or perinatal mood disorder, right? So history of depression, like I shared, anxiety or OCD. So anything like bipolar, previous birth trauma, okay, previous PTSD, that's going to be a risk factor. Any issues with their thyroid or diabetes, that an endocrine disorder, that can be a part of it. A lack of support from family and friends, that's definitely a risk factor, as well as pregnancy or delivery complications. And that's something that we are trying to uncover a little bit more. It's kind of like a silent epidemic that women's experiences have not historically been important enough to ask. And now we are asking women about their experiences of pregnancy and delivery. Having PMS is a risk factor, financial stress and poverty, abrupt discontinuation of breastfeeding. And this is typically because there's a reason, maybe having to go back to work or because of something related to a milk supply issue, but there's something going on in addition to that abrupt discontinuation of breastfeeding. But when we stop breastfeeding, that also changes the cascade of chemicals that are going throughout a postpartum person's body. A history of abuse, and then this issue of unwanted or unplanned pregnancy. Those are all risk factors. But these are just some. We know that adverse childhood experiences also really elevate someone's risk for developing postpartum depression and anxiety, especially if that person's a childhood sexual abuse survivor, because as they engage with the healthcare system, there can be retriggering that happens. Historical trauma and intergenerational trauma, this legacy of having our epigenetics being a part of it, but that people who come from histories with intergenerational trauma, like Indigenous people, they're already kind of primed in some cases for being at risk. And then prior birth trauma or any other kind of trauma is going to put them at risk. So what can be done? So I like this. This is very kind of black and white. You know, the treatment options are counseling, medication, support from your family and friends, exercise, getting sleep, having a healthy diet, using a bright light therapy, doing yoga and relaxation techniques like mindfulness-based meditation, maybe, right? How many of you do this for yourself just to maintain your own health and well-being? Not asking you if you're pregnant or postpartum, but like, I don't know how many of us actually do this. I see a hand raise. Okay, maybe people are just like me, I do it. If you have a question, please feel free to ask. Otherwise, I'm seeing the hand raise as like, I do this stuff. Okay, good. All right, so a few of you, I mean, I think there's a good amount of people on this webinar, and I'm seeing just a few people raise their thumbs and hands, right? So imagine for the people who are parenting or pregnant who are trying to do this, it's almost really challenging. It's very, very challenging to do this, to find time, especially if you have a family to provide for and you have to join the workforce again, right? Especially if you have other concerns from your family members that may live with you or who are close to you, or your priorities just might not be able to focus on yourself because you're expending energy on other areas in your life, whether it's family members who need support, whether it's an infant, a child, a partner, or an extended family member, or friends, whether it's that you have to go back to work, you have a job. There are other financial barriers to this, or just access barriers. So it can be pretty difficult to find the time. But it is recognized that this is where we start. We try to start with counseling. We try to start with support. And then we also try to bring in medication into this. But here are some additional things, especially among Indigenous people, because of our history of systematic attempts at trying to annihilate our cultures and our community and our people. Reconnecting to our community and culture is tantamount. It is really important to do this. Having a sense of who you are and who you belong to and where you belong in the world is really important. And in fact, like loneliness is the number one risk factor for, I believe, suicide, right? Or mental health issues and suicide is this loneliness. So we have to find our place. We're social animals and we have to find our place. So if we're able to connect to our community and our culture, that is going to be protective. So when we come across programs that offer traditional arts and crafts in a community setting where people can come together and not just the mothers, right? Not just the birthing people, but include the family members like the partners and the children, then you're going to be able to be more effective because one, it's really difficult just to have the mother or birthing person come to events like this if she can't bring her family with her, right? If there isn't someone to take care of her family and if there's limited resources in terms of transportation and who needs it. So it's going to be really important to have community involvement and community embracing the family to be a part of this. So then you have traditional practices. I know on our reservation, we had a fatherhood program that was actually helping men in our community reconnect by creating moccasins. They were making moccasins for their children. And so the same can be done for other family members, whether it's making moccasins or making, sometimes people do drum making in different kinds of classes, or it's dancing, or it's a connection through food and honoring of land, or whether it's making a cradle board, which has become more popular, or beading, even just even beading, or making wing dresses, or making tea dresses, but skirt making, ribbon making, these ribbon skirt making, these are all important cultural events that people and communities can try to encourage. And I want to just say too that in urban settings, there is very much a pan-Indian, like a global Indigenous kind of identity, that you'll have people from different reservations, different peoples coming together. And so there's this unified connection of learning how to dance, learning how to make a ribbon skirt, learning how to cook different traditional foods, learning how to use smudging. This is all like doing sweats. This is all important for connection as a group in total. And it's just as important as those that are done in local communities specific to one group of people, right? So it's really important to have this community and cultural connection. Another way to try to help you work your way through this is to seek a friend group, whether that's online or in person. There have been a number of studies that looked at group prenatal care, or the midwifery model is like centering. They call it centering prenatal care, but basically centering prenatal care or group prenatal care actually was based on the circle, like a native talking circle, having people come together, sit in a circle, and one at a time share what they were experiencing through their pregnancy and postpartum. So that those premises were then taken and kind of built into this group prenatal care idea and centering prenatal care. So a friend group is really important, or a cohort. So maybe think about in communities that have the resources and enough people who are birthing, but think about cohorts of group care versus individual care. And there are different hybrid models of seeking that out, but that can be a very powerful way of helping people find friendships and find unity in their experiences, okay? Be outdoors. So the Japanese have the tree bathing, but we also have it as well, like this connection to land, being next to water, being next to the trees, being out in nature. It's very important. I personally, when I am doing postpartum, when I go and see women postpartum and I talk to them about watching out for signs of depression and anxiety, I share with them 3 tips on how to help them through this time. And the first tip is always go outside of your house every day, no matter what, even if it's raining or snowing. Just being outside for 5 to 10 minutes at least. And if you can, try to go for a ride. If you can go for a walk, that's great. If you can't and you can only get in a car, then do that. But try to be outside of your house at least once a day for 5 to 10 minutes at least. The next thing I share with people is to always check in with someone. So have someone who lives outside of their house and check in with them, not texting, but check in with them on a phone call or FaceTime, but to check in with them at least for 5 minutes and at least once a day. And the third thing I often recommend is try to find something really healthy that your body enjoys, that you enjoy, that you like, and do it every day. So whether that is a special herbal tea or whether that is a special fruit, I often disclose that with my first child, my special thing was I would go for a walk, and on my walk, I would get a Frappuccino. And that is not helpful because as much as that sugar and caffeine like really zipped me up, the sugar crash and the caffeine afterwards and the weight gain I got with it was not so enjoyable. But so try to find something that's really pleasurable and that you enjoy, and try to do at least these 3 things every day. Understand that you're not alone, right? Like that your experience of the postpartum depression, anxiety it's not just you, it is universal. It happens to almost everyone. And it just matters when we happen to catch them or screen them. So you're not alone. And so ask people what they did, how they got through it, and see if there's anything that you can glean from them. So having people share their experiences is going to be very powerful, whether you're in a clinic setting or you're in person one-on-one. One of the other things that I kind of shared a little bit earlier about is reclaiming that power of you, that power of the patient in the clinic and hospital. So it is really important that the people who we serve feel safe, that they can ask questions, and that no question is dumb or stupid. And that we have to remember as clinicians, we have to really change how we speak to our clients, to our patients, to our community members, and use words that they can understand, and use images and any kind of props that you can to help people understand. I work with this often in a residency program, and oh my goodness, just to talk about the risks and benefits of breaking someone's water and the technical words that are used, it's mind-blowing. So I always have to kind of remind people to take it down a notch, quite a few notches, to help make sure that people understand and can access what was just shared. I see a hand up. Is there a question?
Yeah,
Ms.
can you hear me?
Yes.
Okay. No, I was just going to add a comment. I come from another country. I come from Brazil, and we took some initiatives in the same thing that you were talking about. So one of the things that we did in Brazil with like a way to break that reclaiming you in the clinic and hospital is that we maternal child health nurses and midwife nurses, we developed a document called birthing plan. So like way in advance before the birth, the mother would list to us her preferences and needs and what she would like, how she would like us to treat her, like whether it was like sitting in a birthing tube or having a shower or not having a shower, or like spaces that she wanted to use and whatnot. But it was a series of like questions that she listed her preference, and we worked with her for her to choose her preferences during the pregnancy. And that document was then attached to her medical records. And it was like circulated between everybody that was taking care of that woman, so that when the time to give birth came, like she had already time to like talk to us about those preferences, and we were informed. And it went all the way to like, if something happens and we need to move her to a higher facility, who are the person that we should contact right away to make sure that she has the company that she needs and whatnot. So like when that document started to be used, there was a lot of resistance, especially from the medical folks, because, all of a sudden you have it in paper, something that binds you, telling you this is what this woman would like. So it was a fight to make it happen, and it took years to get it to be like more used, but it was really worth it.
Thank you so much for sharing that. That's perfect. It is a novel idea to ask people, what would you like? Would you like to have an epidural, or would you like us not to ask you if you want an epidural and you want to try positions and showering? Would you like us to cut the baby's cord immediately, or do you want delayed cord clamping and let more blood circulate to the baby, right? Which we know by outcomes is better for the baby. If there was an emergency cesarean, right? What would you like? Would you like to do skin to skin? Would you like to try to breastfeed within the first hour? Like, I love that. So this, where I work, we have a similar document. It's called Birth Preferences, because we cannot have a plan because plans don't always go to plan, right? But we have preferences or requests. And it's really important to have these discussions with people early on in their pregnancy, so that it's something that they can think about and then have with them. So I love that idea that it's something that stays with the patient's chart and it's there and present, and then it's in writing and people have to look at it. So yes, it is wonderful. So I highly recommend looking into helping clinics, hospitals look at birth preferences, birth desires, and how to handle things like pain medication, breaking your water, induction methods, cutting the cord, skin to skin, when the first bath happens, right? So that's really, really important. Thank you very much for sharing that. One of the things that has also become really important is that chaperones should be accompanying every single exam that is performed. And it does not matter if the provider is female, there should be a chaperone in the room. And I myself experienced as a child a physician who worked in our Indian Health Service clinic who molested me. And that is because there was no chaperone in the room. And that happened in a vulnerable situation amongst vulnerable people, and it still happens today. So it is very important that chaperones are in the room with people. And that second person, that chaperone who's in the room is basically there to make sure that that person is there to feel safe. And it's really important to say, oh, this is Mary. She's going to be here while we do the exam, just to make sure we're all safe. Simple as that. Every single time someone gets an exam, there should be a chaperone. People should be seeking providers that they trust. That is really, really important. We have to have people who we trust in order to come back and get care from them. Oftentimes, Native people, there's research out there that American Indian Alaska Native women have higher rates of late to no prenatal care than other women, whether it's white women or Black women. And this all goes down, a lot of it goes to trust. So there's trust in whether or not you trust the people that you will go to if they are going to drug screen you, because maybe you might have drugs in your system and you are worried that you might have your baby taken away because you might have marijuana in your system or something else. And that trust is so important. But also trust in that if people who come to us and seek care, knowing that there's a high rate of sexual abuse amongst women, and this is just women who report their abuse, there's a high rate of sexual abuse amongst women and violence against women, that there's going to be hesitance to come forward and get care from providers, which is why it's important then to have chaperones. It's really important to have policies that allow people to have that ride or die, or that person, that advocate who's going to be there with them throughout the entire experience, whether it's the prenatal visit, the laboring, delivering experience, or the postpartum experience. That our policies, even during COVID, those hospitals that allowed at least one person in there was anecdotal evidence that women felt better, right? And that's common sense, versus when we completely shut down and had people laboring on their own without any support from their family. This is the last thing I want to share. It's really important that storytelling is a part of this. So storytelling in the form of just asking someone, how did their birth go? What was their birth like before? What concerns do they have about this current pregnancy or the last pregnancy that they're carrying with them into this next experience? What happened during her labor and delivery experience? Was she satisfied? Did she have a good experience? What happened that contributed to her experiences that were not, right? So these are very, very important questions to ask, because sharing someone's story, having her tell her story, can be therapeutic and it can be informative. And this is also a place where we can do interventions. So how powerful is it that someone feels comfortable enough to share with another clinician or another family member or in a group setting their birth experience and the healing that can be done and the support that can be met through that. So this is very important. I'm through some of my work as a consultant, I do help organizations learn how to use storytelling as a method for improving maternal and infant outcomes. And storytelling, especially during the birth trauma or the expectations leading up to the next experience, is a really important avenue for intervention. I would like to end this presentation by sharing 3 generations. This is a photo on the left you see of my grandmother, Kay, and my mother on the right and me in the middle. 3 generations of Salish and Kootenai women from the Flathead Indian Reservation in Montana. 3 generations where we did not have our cultural traditional birth practices. My grandmother delivered at an IHS hospital. My mother delivered at a local community hospital that was staffed by Indian Health Service providers. My grandmother and my mother both shared their story of births with me. And some people may already recognize these photos from other presentations, but I will just sum up their experience that they had horrific experiences. There were fetal demises, so stillborn babies. There were preterm deliveries. There were neonatal deaths. There were hemorrhages. There were high blood pressures. There was postpartum depression and anxiety. So these experiences really affected their ability to parent and to be themselves, and continue to have generational effects on their own children into me. And it is only because I, as a clinician, as I grew to become a nurse first, and then a midwife, and as a researcher, I was able to understand the intergenerational effects of their traumas that they carried with them into their own birthing experiences, but also their pregnancies and later parenting experiences. Them and their older selves sharing their stories helped them heal some of the hurt and pain that they had. And I will share with you that my mother and my grandmother did not have a good bond, that they had a fragmented bond. My grandmother had a really difficult time attaching with my mother. The female-to-female relationship was really challenging in our family. It was easier for my grandmother to attach and bond to her sons, but not to her daughter. And I believe this goes back to their generational traumas that they experienced each. And that carried out in my own mother's generational pain and trauma, and how she was not able to really attach to her female children. It is better now, because now we understand through experiences, through sharing, through storytelling, through research, understanding that we were not crazy, that there were things and experiences that contributed to how we lived our lives and experienced the world. So we are not alone. These women are not alone. It's something that can be universal through trauma and pain, but we have the invitation and we have the charge to step up and change it. 2 examples. You heard from the Alaska Native birth workers community. They're doing amazing work. Please contact them for further information on what they're doing. And then just a shout out to Nicole Gonzalez. She's a Dene woman who lives in Albuquerque, who has her own clinic where she does births and women healing. So it's really important that we look to these people and programs that are making and paving the way for future generations and for other businesses and programs to survive and come about. We're here because of the Hear Her CDC funding. Important to understand the importance of listening to women and hear her. The last slide. Everyone should know this, and I had this on almost every slide. this is a 24/7 mental health support line. It's free. It's staffed by professionals, and there is no minimum or maximum number of times that someone can access this. Please share it widely. Thank you.
Thank you so much, Janelle. You continue to be an inspiration for myself, and I just really appreciate your natural storytelling ability and your leadership. And I really appreciate you taking the time out of your work schedule to be with us today and sharing your knowledge, stories, and experiences with us today in honor of Maternal Mental Health Awareness Month. We wanted to open up now for questions. If folks want to can use the raising the hand function, or that would be helpful, or feel free to unmute yourself and use the chat box as well.
Can you share that website again? I missed it.
Were you thinking of this one?
That one. Yep.
Yep. Everyone screenshot this or take a photo with your phone. And I'll also drop it in the chat. Okay.
Okay.
There you go. Yep. Does anyone have any questions about how to work with families, how to maybe change systems? And I apologize, you're getting me at the tail end of a 20-hour shift now. Yes, Yvette?
Hi, I saw the list of activities that you listed for birthing people to do postpartum. How quickly after giving birth can birthing people engage in these activities? Like the day after, a couple weeks, or 6 weeks?
Yeah. So is this the slide? I have the slide is the treatment options, like exercise. Yes. Okay. Yeah. So it does depend on what kind of birth they had. So with an uncomplicated vaginal birth, I encourage people 2 or 3 days postpartum to try to go for a walk, a very slow walk around the block. Okay. Just remind them that whenever you start doing exercise within the first 6 weeks postpartum, your uterus is a smooth muscle. So it's going to contract as you walk or move your body and do exercise. So there will be a little bit of extra bleeding, and not to be worried about that, just to put on a heavier pad and do a slow walk around the block and then rest. And kind of do that for 3 or 4 days, and then try to increase it up to 2 blocks and 3 blocks. And whatever people were doing postpartum or right before they deliver, some people are walking like a mile, some people are walking like 3 miles. They should be able to do that within a month. People who've had a C-section, they want to wait a good 4 or 5 days before trying to go a walk around the block, maybe even a week. Just kind of delay everything by a week. So that's as far as like exercise. So no swimming pools, no hot tubs for 6 weeks. They can have like a shallow water bath, like what we call a sitz bath, where if they sit in a tub and just the bottom of their bum is kind of covered in water, that's okay. But the uterus is still open the first 4 weeks after the pregnancy. And we just worry about anything coming inside into the vagina, into the cervix, into the uterine cavity. So we kind of encourage people to wait a month before they start using the pool or hot tub, and not to use any tampons the first 6 to 8 weeks, that they shouldn't use any tampons. They should only use pads because we don't want to introduce an infection. But
and the same thing for yoga?
But the thing with yoga is that immediately postpartum, women still have this hormone called elastin that's still running throughout their body. And it takes about 2 weeks for it to leave. So if the first 2 weeks they do yoga, like where they're really opening their legs or stretching, they could potentially move their ligaments in such a way that it'll be painful for them. So for yoga, it's just very, very light stretching, nothing strenuous, like beginner mild yoga. But they can start doing Kegels as early as day, 2 or 3. And I often remind people to do Kegels. It's like being in an elevator and not wanting to pass gas. It's this kind of like way that you tense your muscles, the pelvic floor, and try to do 5 of them when you change a dirty diaper. So when you're changing your baby's diaper, try to do 5.
Thank you.
Hey, Janelle, I got 3 questions, so I'll just go as they come. But the first question from Allison, they stated, you indicated not to only screen once. How long after the birth should you continue to monitor postpartum?
Yeah, so this is where it gets tricky. So the place where I work, we use the PHQ-9, which is a fast, rapid survey. So there are different scales out there. The Edinburgh scale might give you more false positives, but it might not be really good at getting Black, Indigenous, people of colors, depression and anxiety. It might not be able to screen them well enough. So our institute uses the PHQ-9. It's pretty fast and quick, and we do it every single visit that people come in prenatally. And so we always have a PHQ-9 score. And then we postpartum, some people come, they see us either in person or virtually at 2 weeks postpartum, and they're screened then. And some people come 4 weeks and then later at 6 weeks. But we often don't do postpartum care after 6 weeks, right? So then what we do is we've worked with our pediatrician, our peers, and we've asked them to take on doing the PHQ-9 or the perinatal depression screening every time the baby comes in for a baby well child check for the first 2 years of life. So what it comes down to is it's really cool to be able to give people like an iPad and they can fill out information and it goes automatically into their chart versus having them fill out a piece of paper, which might make them feel more self-conscious if they have to fill out a piece of paper and then hand the paper to someone like at the desk. But if they can do it remotely on an iPad before they come into their appointment, the day of, or while they're waiting in the waiting room, and then they can hit send and it goes electronically into their chart or to their provider. My sense is that people might be a little bit more forthcoming about how they really feel versus having someone look at it as they're like taking it to the provider. Great questions. For moms, I see. Why does the Edinburgh scale not work? I'm going from memory. There is an article by Heck, H-E-C-K, and Heck evaluated the Edinburgh scale. And I think it's just that the questions have not been culturally, the psychometric properties, like the ability for this scale to really find depression, anxiety has not been studied well in the American Indian Alaska Native population. And I think that that's the biggest issue, is that it just hasn't been studied well in our population, and that there could be other facets, other ways of asking about depression and anxiety that the Edinburgh scale is not getting to, that people of color might frame their depression or anxiety more. So for example, neither of these scales ask you, whether that's the PHQ-9 or the Edinburgh scale, neither of these scales ask you how much time you spend on your phone doing screen time, right? But that would be something that would be really important to ask, is like, how often do you find yourself drawn to escaping, right? By looking at your phone or something. Yeah, exactly, Heck. And I think it's like 2021. And I think this is the person who wrote the article evaluating the Edinburgh scale. And then the question for moms who have a baby born with an abnormality, what's been my approach and experience with working with them? So with people who are known to have, my children are going to be so happy because they won't be able to hear me speak when I tell them to stop watching TV or do their chores, right? So the people who go through screening and are identified prenatally, if they have a baby with a fetal anomaly, it is really good practice to try to help them understand that they're going to be at risk of having depression and anxiety. And also, one of the things I didn't share is that if someone has during the delivery, if the baby is admitted to the intensive care unit, that family, that parent is going to be at risk of depression and anxiety. And that's not something that's been captured on a lot of this research. But if you have a family member, like the mother whose baby is admitted to the NICU, the intensive care unit, then that person's going to be at risk of depression and anxiety. So if you can prenatally find people who might be at risk and talk to them about they're going to be at increased risk, potentially because their baby might have trisomy 21, or they might have some other kind of fetal anomaly, it's really important to start that conversation then, and then continue it postpartum and keep screening them postpartum. So those people should ideally have a check-in at 2 weeks, a check-in at 4 weeks, a check-in at 6 weeks. It's really important to postpartum to keep these people who are at risk, who have risk factors, keep seeing them every 2 weeks, even if it's a virtual visit, just to check in.
Oh, Janelle, can I ask the next question that I found? Leonie was asking for more information on the impact and relation of nutrition and how it can support healing.
So, Leonie, it's a wonderful question. I am not an expert in nutrition, although that is an interest of mine. So I do not have the information to adequately share with you the importance of nutrition. But yes, like whole foods in general, like hands down, there's a lot of research that supports whole foods in general, like your vegetables, your grains, your fruit, not processed food like cheeses and milk. That whole foods are going to be very, they're going to help you with your mental health. That you just have better outcomes when you eat whole foods in general. I'll leave it at that.
Okay.
It's always better to eat the food than it is to take the vitamin. And if you can't eat the food, then you take the vitamins. But it's always better to get your vitamins through your food. Okay.
Sorry, I couldn't find my unmute button. Okay, so the next question that I have is, do you see a need for new/different screening tools for Indigenous women and birthing people? I think that's a really good question.
Yeah, it is.
All these are great questions, by the way.
Yes. You know what? It would be wonderful to see a new screening tool. Yes. Because I believe that, and research supports this, but that one of the risk factors for postpartum depression, perinatal mood, like anxiety and depression is being a member of a Black and Indigenous community, people of color, right? And that's because of our history. That's because of social determinants of health. So yes, the fact that the Edinburgh scale, which comes from England, does not adequately track amongst Black birthing people their experience of depression shows me, indicates to me, the researcher, that we're not asking the right questions to get at what might be nuanced. Like, here's an example. By show of hands, how many people know what it means when you say to someone who's pregnant or postpartum, oh, be careful, that might give you a setback? Okay, Yvette, what does that mean? What does a setback mean?
Like, you can go back to your, I guess, a lower level of functioning if you go outside too quickly or do something else
Yes.
before it's perceived to be time.
Exactly. So Yvette is sharing, let's say someone just had a baby and the next day they go for a mile-long run
watch out, you might have a setback. You might find yourself bleeding a lot and having to go back to the hospital, right? That's a setback. But a number of us don't know what that means because that's not our culture. That's not how we talk about postpartum health or pregnancy health. And in the Black community and culture, a setback, it's a spectrum of things. It doesn't mean just one thing. It means like a lot of things. And so if you can't adequately use your language to help address something, then you can't define it well. And so that's the problem with some of our scales. And I understand we need standardized scales, but it would be interesting to see a Black, Indigenous, BIPOC scale, because I believe it would probably accurately capture what we do. Like here's another example. How many of you can relate to seeing a pregnant person come in who is just like checked out? Like they don't want to be there. They're really hard to get into the clinic. They don't want to be there. They're like terse, they're irritable, they're kind of nasty, like they're just in a mean place, right? I've seen that. That actually is what that person is exhibiting is postpartum depression or perinatal depression and anxiety. Like that person who is irritable, who doesn't want to be there, who's bitter, who's like challenging everyone and like not having, like making everyone's day just go down the tube. That person needs help. And that person is in despair. And that person needs a lot of resources. So if we can't adequately use the language and tools that is culturally relevant to that person, we can't help them.
Yeah, I think we have room for a few more questions. I have this question on hand do you have any suggestions or ideas on how WIC can be helpful in supporting birthing people?
Yes, how can WIC support birthing people? Yeah.
Yes.
Yeah. No, so WIC is a hub. WIC is the place to go. Like once families can get connected to WIC, right? It is the gateway to mental health screening. It could be. It's the gateway to helping people with like group care, like, potentially like the potential of WIC is so amazing because we know typically people who get WIC often then have Medicaid. They have access to healthcare at some point during their pregnancy. Maybe it took them a while to get it, but they have access, right? So WIC is a really great primary hub where so many other interventions can happen, whether it's screening for mental health concerns during family check-ins and assessments of the family, screening for violence, okay? It can be a place where people can come together and get resources for mental health issues, or a lot of times in Native communities, the WIC office is right down the hallway or next to the traditional, like the traditional knowledge and like working craft area. So like you'll have people that will do a WIC event, but they also have like some sort of like arts and crafts component to it that is traditionally based. So WIC is, in my mind, can be a stellar opportunity and the foundation postpartum and prenatally where people can come and not just get access to food and resources, right? But can actually have access to some health and well-being. We should have WIC and HUD housing together. We should have WIC housing and judicial, like the what am I trying to say? Like the tribal court system, the tribal police, the police force, like they should all be sharing the same space, because I think that they would all understand that in having and sharing space with each other, not just physical space, but sharing space with each other, knowing that the population they're working with, there's going to be understanding amongst them. And why do women go to jail? Why are women imprisoned? The number one reason is because they were providing for their families, and that's universal. I could go on and on, but you're all lucky because we're running out of time and my voice is going to give out.
Yeah, and we have time for one more question, comment. Thank you so much, Janelle. Seriously.
It's my pleasure.
So, yeah. Dr. Palacios, one of the things that we are dealing here in South Dakota is the maternity care deserts. It's counties that have like nobody, no midwife, no OBGYN, not even a family practitioner to start the prenatal care. So families have to travel a long ways. Do you have any like suggestions or ideas of like how we can bring care to those areas? Or in your experience, have you seen something that helps with that?
Yeah. Okay, here's some ideas. All of our small communities have a Walmart. Do you have a Walmart in those communities?
Yes, ma'am.
All right, Walmart. Who would have thought that Walmart potentially could be the haven for healthcare? So what I think some novel approaches are, there are some clinics that are attaching themselves to Walmart actually, and they're giving care. So that is one thing that we could do, right? We could get into these areas that are like deserts, South Dakota, maternity care desert, like the Dakotas and Montana and Wyoming, Alaska. Like you could attach clinics, whether it's just 2 or 3 times a week, but you could attach clinics to Walmart areas and have clinics there, or whether it's a mobile clinic that goes there, but you have a meeting place. Another one is, definitely the family home visiting program. That's been popular, and I think that's been done in the Dakotas. There's a family spirit program out of Johns Hopkins where they have done a lot of research looking at, with federal funding, to pair nurses in a home visiting program where they go to people's homes. Getting access to homes is a whole other issue, and it takes time and trust in building that. But that's another, that's something that does happen more frequently. Another idea are these ideas of pods, like pods that are pretty much like you staff up birth workers, like train people to be birth workers, like doulas, where it's easily accessible to get some sort of education where people can then just understand like symptoms or things that need to be triaged to a higher level. So if you have people like community health workers, which is kind of like what a birth worker could be, where there is some education and training, but these are people that live in the community, that are in the community, and that they're usually social butterflies, and they are in everyone's business, and they know what's going on in their community. And so they can, with their education and training, identify people who need extra help and then call in resources for that person. So those are kind of 3 big ideas that are kind of being talked about. So if those are going to work in South Dakota, or those give you ideas of what's going to work in South Dakota, like you say, oh, maybe this won't work there, but maybe something like this might, then you need to contact HRSA, the Maternal Child Health Bureau, and let them know, because they need to know that novel ways of helping reach care for women is really important, because we know the regionalization of perinatal services is not working, because women are traveling 3 hours to go get help if they have a car, and if the roads are nice and the weather's good.
Thank you so much, Janelle. We'll end it there. We really appreciate you, and we hope you get lots of rest after this and safe travels back to your home. And thank you everyone for attending today's session. Our last session will end on June 27th, so we look forward to seeing everyone there. And if we appreciate if you take the time to fill out our evaluation. So thank you so much, and thank you very much, Janelle.
Yes, my pleasure. Thank you for having me.
Of course. Thank you, everyone. Have a good day. We'll see you guys. Bye.